Good morning, everybody. Thanks so much for joining me this morning. Got another interesting topic for you today, and then we'll do an extensive Q&A. Today's topic is basically defining recovery trajectories for ePICL. What does that mean? We'll get into that, but basically, every procedure has different recovery trajectories. There are usually a couple possible, meaning we all probably know patients that get certain surgeries and they breeze through them, and they're way ahead of where their surgeon expected them to be from a rehab and functional standpoint. We also know patients who are about the average, and we know patients who are behind the curve, right? A surgery that was supposed to take someone out for 3 weeks takes them out for 3 months, kind of thing. So we're going to get into that today, and then we'll go to extensive Q&A. Again, Q&A is really a fantastic opportunity for everybody to learn. So if you want to ask questions, if you're on YouTube or on Facebook, just go ahead and put that question in the comment or comment section. Then I'll see that on my end and try to get those in earlier rather than later, because invariably what happens is at the end of the day, towards the end of this presentation, I have more comments coming in than I can answer, and some don't get answered. So try to get those in as early as possible, and don't be shy, ask questions. Again, the more questions we get on different topics, the better it is for everybody watching. So let's get into this topic first, and that is defining those recovery trajectories for ePICL. And then we'll get into Q&A. So let's start here. So all surgical or interventional procedures have a typical recovery curve. Now, it's interesting. I think most patients understand this, but some don't, right? Some believe that a procedure is more like a commodity, or let's say an experience that you might get or service, where it's predictable in some way. And it is generally predictable, but regrettably, or maybe for good reason, we all have different recovery trajectories from every single procedure. So for instance, a couple of weeks ago, my wife got a surgery. She's well ahead of the curve. Why is she well ahead of the curve? She was super duper duper healthy, had better labs, for example, at age 60 than she had at age 25 or 30, and was super fit. And as a result, she is probably 2 or 3 weeks ahead of most people who got that same procedure. So let's get into this for ePICL. So for example, this is the recovery trajectory for cardiac surgery. And this is a paper that was published that looked at a bunch of different sort of average trajectories there with percentage recovered and then the time since the surgery. And you can see you've got from the top curve there, a huge difference than from the bottom curve, right? At the top curve, at, for instance, 20 days, you've got patients who are reporting only being about 35% recovered. And whereas the best responders at that same point are reporting being about 82, 83% recovered. Again, take it out to 30 days, and we've got there at 30 days, the least recovered group is only reporting 40% recovery, and the most recovered group is reporting all the way up to 100% recovery. So we're going to look at all of this, not in terms of time necessarily, but in terms of the number of PICL procedures. So this week, I produced this recovery curve, basically looking at the as-seen patient case series, and then looking at the number of PICLs that patient had received, and then looking at the average SANE scores for those different milestones. So 2 PICLs, 3 PICLs, 4 PICLs, etc. So you see here the dots are the median, and then you've got the bars there, the solid bars. That's the confidence interval. And then you've got the range, which is the dotted line. So you can see, even though we can calculate a median, the range is fairly broad there, right? So at 3 ePICLs, for example, the median recovery is going to be about 50%, let's say. But we've got the range that goes all the way up to 90-some% recovered on the top side, and on the bottom side, all the way down to about 20% recovered. So obviously, within this data, there's going to be people who are recovering on different curves. And all we're seeing here is the average of those curves, or the median of those curves. So I then looked at it further, right, and defined these 3 general recovery groups within that larger group. So this is about 200 ePICL procedures and follow-ups. And what you see there is you can define kind of the lowest one here, which are the slow recovery patients. Again, this is number of ePICLs. And then you've got sort of an average group that looks a little bit more like what we saw in that last slide when we looked at everybody. And then you've got the super responders here who are reporting an awful lot of improvement at that first check-in after their first PICL, and then kind of goes up from there. Let's go back here a little bit. My bad. So again, these people are reporting a lot of improvement and then kind of plateau out. And then this is the percentage of the total population that we're dealing with there. So at the end of the day, as you can see, we have these 3 groups that are part of that more amalgamated data. So the big question then becomes, if we have these sort of average recovery curves, we got the median one, and then we've got the 3 that live inside that data. But what happens when your recovery trajectory kind of goes off the beaten path? So let's get into that a little bit. So this is one that's definitely buried in there, and there's not a lot of these in that data set. I suspect that as we get to 300 and 400 and 500 patients in that data set, we'll see more of these. But this is clearly in there, and that is what I would call delayed takeoff. And that is after PICL1, there's kind of a 0 to 15% improvement. Why do we use 15%? Because studies have shown that 15% is kind of the smallest reliable chunk that patients can report with regard to improvement in medical research studies. So for instance, if we're reporting 10% improvement, the research tends to show that's about the same as 0. But if we're reporting 20% improvement, that's over that 15% chunk. So that's probably meaningful, for example. So we have these delayed takeoff patients. They don't do so well with 1, but they do much better with 2. So based on my experience, most patients who don't respond to ePICL initially will respond meaningfully to the second procedure. Now, it's important to note that this is a relatively new phenomenon for us because as of about 2 years ago, I generally didn't let anybody who had failed, or very rarely, a first procedure go to a second. So it's only more recently we've been opening that gate slowly but surely and trying to experiment with that to say, okay, if you fail a first, is it possible that you would respond to a second? And as I've done that more and more, I see a pretty typical response. About 60% of these patients who aren't responding from number 1 respond to number 2. Now that still leaves 40% of them who aren't. And then at that juncture, after number 2, we're telling these patients they probably need to get a fusion. So what if your recovery is like this, which is what we just talked about, right? What I would call a no-go, meaning that they didn't respond well to number 1, they didn't respond well to number 2. Time to get a fusion or choose another path. So just realize that, as I said, some patients who don't respond to a first ePICL won't respond to a second procedure. Most will, but some won't. So if you're in the some won't category, it's time to move on. Now, you can either move on with regard to getting an upper cervical fusion, or sometimes these patients are just on the wrong path. There's so many different rabbit holes within this CCI vertical and within the CCI patient population, i.e. CSF leaks, Ehlers syndrome. You can go down the list of different things that people are exploring. And so it could be that they're on that wrong pathway. Here's another one. We don't see that one this often. I'm sorry, we don't see this one too often, but it definitely happens. This is what I call the crash and burn, right? They seem to do well for 3, 4, 5, 6 weeks, 8 weeks, and then they kind of crash and burn. Now, I've got a crash and burn protocol, and most of the time, the crash and burn protocol explains what's going on here. And so this is based on a couple things. First is, first is activity. Did your activity change? So a good example here is we've got a bedbound patient who all of a sudden starts to feel better. They get up, they start doing more, let's say chasing after kids, let's say starting to do things that they definitely weren't doing before, and they do too much too soon. So that's an easy one, right? Pull back from those activities. Another common one that explains this is medications. We have patients more and more as time goes on who I would say are dependent on specific medications to function. They might be dependent on nonsteroidal anti-inflammatory drugs like Motrin just to get through the day, or they might be dependent on CGRP headache drugs just to get through the day, or they're dependent on a steroid or other powerful anti-inflammatory just to get through the day. Now, we take them off those medications because we don't want those medications interfering with the procedure, but then they crash and burn. So sometimes we need to then decide to put those patients back on those medications for which they became dependent so we can get an apples to apples comparison. So that's a big one. Another one is treatment, right? I think we just saw this sort of making the rounds on social media this last week, where we had a patient who took it upon themselves to start AO chiropractic after the procedure because they were convinced by social media that that's what they needed to do, even though that's not my recommendation at all. And it wasn't a good fit for them. And so they crashed and burned. Now, again, if you want to do AO chiropractic, learn that before the procedure to see if it's a good fit. Most of our patients do well with it. Some of our patients crash and burn with it. You don't want to be after a procedure adding something in new that you might crash and burn from. So that's a good example there. And then injury, new injury. That's not uncommon. Once I tease it out from these patients, we'll find that they had a fall on the ice, for example, they hit their head, or they were getting in and out of an unfamiliar car like an Uber and they banged their head. So these are things that we look at when we see these crash and burn trajectory patients. I call this the crash and burn protocol. And 90% of the time, it's one of the things on this list. So just to sort of wrap this up, again, I discuss this all the time, but I want to discuss it again in this context. What is the ePICL success rate? So from the registry data set I've been analyzing in the as seen case series, the success rate remains about 7 out of 10. The same thing we're seeing in the registry data set as well. And in a perfect world where everyone who should come back for a second procedure does come back, i.e. we don't have the financial constraints that sometimes drives that, that likely increases to 7 to 8 out of 10. But that still leaves 2 to 3 out of 10 patients who don't respond meaningfully enough to avoid fusion. So that's important to understand. Okay, I see tons and tons and tons of great questions coming in. So let's go ahead and start to get to those questions. Let me switch this out here. Maisie, do you treat trigger points in the muscles at the same time as a PICL? And if so, with what? And is that treatment better than dry needling treatment? Thank you. We can treat trigger points at the same time as an ePICL. The most common ones would be upper traps, sternocleidomastoids, levator scap. Those are super common ones. We use platelet poor plasma, which has been shown in basic science studies to help improve muscle repair. Now, is that better than trigger point dry needling? I don't think anyone knows the answer to that at this point. Theoretically, it is, but clinically, I don't think that's ever been tested. Same poster. Can you see a connection between pain in these three places, the upper part of the shoulder blade, the facet joint at 1, 2, and pain in the eye? So yes and no. There may be a connection there, meaning you can get, for instance, upper trap or sternocleidomastoid trigger points that can refer pain into the eye. You can get, for instance, irritation of the C2 dorsal root ganglion, which can cause referral of pain into the eye. That's at the back of the C1, C2 facet joint. You can get irritation of the greater-occipital nerve, which can come over this way, back here, which can cause similar things. So those things may be related. Those things may be unrelated. Typically, how long is a patient under during the ePICL? So during the ePICL portion of the procedure, a lot of that's going to depend on the complexity, the facility of the doctor, meaning how many procedures have they done, etc. For my patients, we're generally talking somewhere between 40 minutes and 60 minutes. I would say on average, probably 45 minutes, somewhere in that time frame. And then the person goes to recovery and usually spends about an hour in recovery. Now, if a doctor doesn't have thousands of these under their belt, then, or 1 to 2,000, then that may be a bit slower. So you may be looking at 60 minutes, for example, or 70 minutes on average, somewhere in that range. Kaylee, how does treatment of recovery differ with someone from, let me say that again. Kaylee, how does treatment of recovery differ for someone with Ehlers-Danlos Syndrome? EDS certainly means a longer recovery trajectory, but I continue to be astounded by when I look at the total outcomes after 2 procedures. EDS isn't predictive. So it's not a big difference from the average person. And that's been surprising to me, right? Meaning at the end of the day, if I run the outcome in the registry database, for example, against, and I can be looking at neck disability index, SF36, physical functioning, pain scores, SANE scores, etc. And I go ahead and look at the failure rates after 2 procedures for either self-reported HEDS or just related to Beighton score. There isn't a difference between those 2 groups. And I've run it in the As Seen case series. We've run it multiple times now in the registry database. So my overall sense is they probably recover a little more slowly, but there isn't a meaningful difference between HEDS and not, because now I've run this thing a half dozen times, and you would think that the numbers are big enough, the N is big enough, so if that was a clinical signal, we would be seeing it at this point. Blessed, seems like you are the most experienced on ePICL. Let me start over again there. Seems like you are the most experienced on ePICL at the clinic. which other doctor at the clinic would you say is the next most experienced? Probably Dr. Schultz, simply because Dr. Schultz was really there doing the anesthesia with me during the first PICL procedures, meaning I wouldn't trust anyone but Dr. Schultz to do the anesthesia for those early procedures until we got maybe 400 cases. And then we started bringing in trained and experienced CRNAs to do it, who could gain experience with that procedure and who could talk to Dr. Schultz about some of the things that were different. So Dr. Schultz by far would be in that second position. And he's now doing a good number of these each week. So he is definitely catching up. Stephen, do patients report reduction in tinnitus symptoms after a posterior PRP injection or a PICL? Not so much after posterior injections. We certainly see that pretty commonly after PICL. Hello, Edgar. Hello, Dr. C. Are you familiar with shockwave therapy? And is it the same for connective tissues related to cervical CCI? Also, can testosterone replacement help CCI recovery pre or post ePICLs? So the first one on shockwave, I am very familiar with shockwave. Will shockwave help CCI? No, not in my opinion. Certainly not if that CCI is due to internal ligaments, because that shockwave isn't going to come anywhere close to those internal ligaments. Now, you can get some relief, though, because a lot of patients with internal ligament CCI have problems that are more superficial, greater exit nerve, lesser exit nerve, tendinopathy back here. Those things could be responsive, but it's more symptomatic improvement. Then when it comes to testosterone replacement therapy, that's an interesting one. I would say the answer is supposed to be yes, but we did a testosterone replacement therapy stem cell study many years ago. We didn't publish it because the results were kind of contrary to what we had been told. We had been told that if you did testosterone replacement, that healing was faster and hence stem cells should be better. And we did a pretty detailed study and the stem cells were not any better. So at the time, my thought was, are we going to publish this, not publish this? It took a lot of time and money to do the study. We literally did 20 patients who weren't on testosterone therapy, but were in andropause. And then we optimized them for thyroid and testosterone, took bone marrow aspirates at both time points, and then looked at the bone marrow aspirates in the lab. And we couldn't demonstrate that their stem cells were functioning any better in any way, shape, or form. So we just didn't publish it, mostly because it's kind of like a wah-wah type thing, meaning we didn't find something that seemed super interesting at the time. Vera, hello, Dr. C. I had my PICL number 1 a few days ago. Just wanted to say it was a good experience. Everyone was very caring and professional. I was in excruciating pain for the first 24 hours, but better afterwards, hoping it will help with my symptoms. Well, great to hear, Vero. That's pretty common. Again, that's maybe another lecture, is to go through those recovery trajectories. I could probably start recording that, meaning what percentage of patients have a lot of pain that first day, what percentage of patients have substantial but controllable, etc. But that's pretty common. You're going to have a big flare that first day. It's going to get a bit better by the second day, a bit better by the third day. Pretty common with all surgical procedures as well. So thank you for that feedback. But at the end of the day, I'm so glad to hear that things are calmed down, and I hope as well that this is the right fit for you. Vera, how many weeks after PICL could I try swimming if it used to make me symptomatic? Vera, you shouldn't really try anything in recovery that makes you symptomatic on purpose, right? That's part of that thread the needle recovery. What we're trying to do there is to remain active enough where you can increase strength in those muscles, but you don't want to piss it off. So, for example, if what you're telling me is that if you went swimming prior to the procedure and it always reliably increased your symptoms, then you should stay away from that while you are in recovery. So that's going to be a full 3 months. Now, having said that, let's say you told me I used to go for a walk for a mile and it didn't really increase my symptoms. It actually felt good just to get out there. Then I would say you could do that as soon as those symptoms from the flare-up return to normal. So you see the difference there in threading the needle between something you know flares you up, which you want to avoid, and something that really doesn't flare you up, but can help with strength. Nathan, how do you determine if someone is a non-responder, is more related to symptoms or stability improvement? So Nathan, non-responder is based on a couple of things in the research that we're doing. So validated functional questionnaires, we use the Neck Disability Index, the SF-36 physical function score, the headache impact test, the HIT, and we also use numeric pain score. We also use SANE, single assessment numeric evaluation. So that determines who the failures are, meaning if they're not meeting the MCID or minimal clinically important difference on those questionnaires. Regrettably, I know this is sort of the social media influencer craziness out there, but we've looked at DMX and whether DMX correlates with recovery or recovery of symptoms, and it generally doesn't. So we've got quite a few cases where the DMX overhang is improving, for example, but those patients aren't reporting changes in their symptoms and vice versa. Now, where we will use DMX is if basically as a tiebreaker, right? We're trying to figure out if somebody is on the right path. So let's say someone does a single procedure and there isn't any improvement clinically, meaning in symptoms or in function, but we're trying to see if we're on the right track. And that kind of makes sense to me to repeat the DMX there. And we do that quite a bit. And we say, oh yeah, it seems like we're making some difference here. So we'll continue for a second time and see if you respond. But regrettably, I wish it wasn't the case because it would make my life much easier. There's not a correlation there. Now, why wouldn't there be a correlation there? I think I've put this on the Reddit thread quite a bit. There usually isn't a correlation there simply because at the end of the day, structures get beat up that cause symptoms, nerves, joints, etc. And when those structures that cause symptoms are still having problems, even if you reduce the instability, you still get the symptoms. Stephen, have you experienced patients report symptoms of tinnitus-like symptoms like ringing that feels as if it's coming from the center of the head rather than the ears? Yeah, Stephen. So tinnitus can take on a couple forms. One is sort of that constant ringing that patients don't necessarily localize to the ears. Sometimes it feels like it's coming from the head. And the other big category would be pulsatile tinnitus or tinnitus that has a pulsation type character to it. That tends to be more IJV related. And then a subtype within both of those would be my tinnitus is impacted by moving my head around. And that usually tells us that it's coming from the neck. So yes, we do experience patients who have tinnitus that feels like it's not localized to the ears, but sort of coming from somewhere in the head. Christy, can you make the graphs the main screen so we can see the information better? Christy, I may then just, if you're interested in those graphs, record a separate video on that simply because at the end of the day, it's hard for me to record clips. I clip all of this for the YouTube shorts and it doesn't work so well if the screen that has the presentation is too large. Rebecca, I went to another clinic for upper cervical prolo. I'm not having severe feelings of jugular vein compression to us. don't know what that means, Rebecca. So maybe if there's a question in there, I'm not quite sure what you're trying to relay. So maybe if you could go ahead and repeat that or give me more details there. The dude ski. What did the computer say when it fell into the? Okay, so we got ourselves a troll there. Zach, how would you expect culture expanded stem cells to compare with BMC with regard to treating ligament laxity? Does this depend on the number of cells and/or inflammatory response to the treatment? Yeah, Zach, I don't think there's a big difference between those two. I've probably got more experience than anyone on the face of the earth. I'm almost positive that's a true statement, with using culture expanded stem cells for ligament repair and using bone marrow construct for ligament repair with direct injection into the ligament of either the first or the second. I don't see a big difference between those two for ligament repair. Where you can see a big difference between those two would be for things like more severe osteoarthritis, more severe bone issues, more severe tendon tears. So again, not in this CCI population, but in those instances, or for instance, using hypoxic cultured cells to try to treat a disc bulge. In those instances, culture expand cells can have an edge. That would be autologous, your own, not the allogeneic. But you're not going to see a big edge in ligament applications like we're using here. So a good example of that would be the ACL work we do or the CCI work that we do. Stephen, ideal health tips preparation for something like posterior PRP, habits, etc., for optimal results. Well, Stephen, I think the biggest thing you can do is to not have metabolic syndrome. That's the single biggest thing I think most Americans can do in general for their health, because we have a lot of Americans with metabolic syndrome. So what is metabolic syndrome? Metabolic syndrome is what you see every day, right? As people get older, they put on weight, they start to get high blood pressure, they're less active, their blood sugar control goes south, their triglycerides go up. So I would say the single biggest health thing you can do is to get rid of metabolic syndrome, whether that's going on a GLP-1 and losing the weight, whether that's being more active and losing the weight, which can be difficult in CCI patients, whether that's going on a low glycemic diet so that you're not exposed to all the sugar. So for example, got to get rid of the Starbucks, mocha, frappuccino, whatever the heck that is. That's got to go because those things have 70 to 80 grams of sugar. It's like drinking half a cup of sugar and water. So that's probably the biggest thing you can do to improve your overall health, for any regenerative medicine procedure. What is the typical dose of culture expanded stem cells for treating tendinopathy? What about a loose ligament? You don't need a lot of culture expanded cells for doing that, but a lot of that's going to depend on what we're talking about for culture expanded cells. So at the end of the day, we're talking about normoxic, conditioned, autologous, bone marrow derived culture expanded cells, hypoxic, conditioned culture or bone marrow derived culture expanded cells. Are we talking about allogeneic cells? If so, what type? But I can tell you, for example, for the first type, it would be in the low millions. That should do you just fine. Again, you're not going to see, though, a big difference there in overall function between that and bone marrow concentrate. JS, good morning. How do you prep your body before and after surgery? Is such a thing as changing diet, adding moving supplements? How to detox anesthesia since older folks don't tolerate it? Older folks tolerate anesthesia just fine, so I don't know where that comes from. Again, I was talking about my wife before. She was in excellent physical condition, went into a surgery, is ahead of the curve on recovery. She's ahead of the curve on recovery because she was an excellent shape beforehand. She was physically fit. She ate well. All of her hormones were in check, et cetera, et cetera. So if you want to prep your body before and after surgery, I would go back to my prior comments on metabolic syndrome. The single biggest impact, other than getting rid of smoking or exercising on a regular basis, that you can have in the United States to improving your overall health is to stop getting the Froca, Mocha, whatever they are, Frappuccinos at Starbucks, which have 80 grams of sugar, and go on a low glycemic diet, get rid of metabolic syndrome. If you've got extra weight, lose that extra weight. That's really the single biggest change that you can make in order to try to improve your overall health. So that applies to the vast majority of Americans who are over the age of 40. And obviously your health for a regenerative medicine procedure. So if you had to just say, what's the biggest bang for the buck? That's it. Casey, what CCI diagnoses do you feel that only your clinic can or should take on? Or what can another regen center take on with your blessing? One clinic can't care for the entire world. Yeah, Casey, our focus is on the ePICL procedure. Now, we also do an awful lot of other types of CCI as well. So our expertise is going to be in that PICL procedure that I invented and have perfected over the last decade. In addition, it's going to be the experience of injecting the high upper cervical spine deep. So that means the 0-1 facet joints, the 1-2 facet joints, those injections that are much higher risk than other types of neck injections. Now, when it comes to, for instance, CCI type 3A, where C2 is going forward on C3 inflection, God, that can be treated by lots of different clinics with just good ultrasound guided prolo of the supraspinous, interspinous ligaments, nuchal ligament, VDL, etc. Having said that, when you then go deeper and you try to inject those deep upper cervical facets, 1, 2, and 0-1s, then you're getting into higher risk procedures and a higher risk of harming the patient in some really bad way. And that's why we specialize in that, meaning, we're open to any clinic developing a history base of thousands of upper cervical C0, C1 injections, for example. But that doesn't exist. I don't think there's a clinic on earth that has done thousands of those procedures. So that is what that is. I don't know what to tell you there. Most interventional spine doctors that have tons of experience, who really inject anything in the body and are super experts in getting into the right places safely, will avoid those levels. Why do they avoid those levels? They're harder to do. They carry more risk. And so they don't have a lot of experience there. And as I always say, medicine's no different than anything else. You've got a lot of experience, you're going to be very good at something. If you don't have a lot of experience, you're not going to be very good at something. And then on the ePICL, that is what it is. We are, as I said, working with a Florida clinic to try to bring them up to speed. We will slowly expand that out and train clinics over months and years to get them up to speed so that they can do all those things safely. But neither one of these is a see one, do one, teach one. So what I mean by that is they're not the kind of thing that someone can learn in a weekend course and do safely. They're not the kind of thing that someone can come in and see 2 or 3 and go home and do safely. That would be super irresponsible on my part, and I don't go there. I have MCAS. Could I still have your procedure? Sure. Yeah, I would say about 1 in 4, 1 in 3, somewhere in that range of our patients have MCAS. They do just fine. I've just looked at that data in the registry database, trying to see if self-reported MCAS had anything to do with the procedure outcome. It does not, meaning it doesn't improve your odds of outcome with the procedure. It does not decrease your odds of outcome with the procedure. It just wasn't a clinical signal at all. Meaning, when I say that, what I mean is at the end of the day, in looking at the registry data, MCAS was not a predictor. Didn't matter if you had MCAS or did have MCAS or didn't have MCAS, your outcome was the same. Sage, why don't you take Medicare? I don't take Medicare. That actually, for our clinic, stopped after the, let's see, it's probably 2010 timeframe, somewhere in there. We do take all the big insurers, Blue Cross Blue Shield, United Healthcare, Cigna, Aetna, you name it. But we don't take Medicare simply because the administrative burden with taking Medicare is just too high. And we weren't interested in dealing with that administrative burden. Regrettably, the government has made that administrative burden insane. And so we just checked out. We said, no, guys, we're not going to do this. If you want to keep the administrative burden the same, for instance, as taking United Healthcare, we're happy to take it. But if you triple or quadruple the administrative burden, which happened around that 2010 or so timeframe, we dropped out. There was no rationale to continue taking it. Stephen, common for main symptoms to be sensory overload, sensitivity to light and sound. If you mean common for CCI patients, Stephen, yes, that would be common for CCI patients. Before I go ahead and proceed and answer a bunch more questions, please give me a like, share, comment, subscribe. The reason for doing that is it's a good way to pay it forward to the rest of the CCI community. I'm obviously volunteering my Sunday morning here to answer your questions. I volunteer, 10 hours a week, 5 hours a week, something like that, of my time answering tons and tons of questions on Reddit. It's how I pay it back to the CCI community. And I'd like you to do the same, because if you like, share, comment, subscribe, what we see is that the algorithm picks up on this stuff so that other CCI patients can find this content. And if other CCI patients can find this content, they can then come and ask their questions. And that helps everybody because the more questions we get from different angles, right? You're concerned about this, I'm concerned about that, another patient's concerned about something else from a different angle, the more that helps everybody. Sage, I think I answered that one already. Go Tyler. It would be neat to see a simple regression which shows at each recovery curve which variable is most predictive of each group. Yeah, that's what we're doing right now. Now, never going to really look at insulin sensitivity, muscle mass, inflammatory markers, because that doesn't really make sense for our practice. But that's what I've been doing for the last 6 weeks or so, somewhere along those lines, meaning I've been querying the registry database for lots of different variables, performing many different types of regression analyses, Bayesian analyses, etc., in order to try to see if there are obvious factors, including looking at things we do have, which would be, grab oaks. Does the size of the grab oaks make a difference in recovery or outcomes? It doesn't. Clavoaxial angle, does CXA make a difference? Does having MCAS make a difference? Does having EDS or a high Beighton score make a difference? It doesn't. So I've been looking at all of that stuff. So if you follow the Reddit thread, I'll sometimes periodically, as I see something interesting and all of those different analyses, many of them are regression analyses, I'll post that because it's kind of fun for me, right? I've just found something that looks like it could predict outcome. So it's fun for me to get it out there and say, hey, here's some interesting stuff. We'll see if once the research team pressure tests this, whether it's a real effect, meaning, the first is my analysis, it seems to be a real effect, then it goes to the research team and they try to pressure test it to see if someone else doing the stats, looking at it in the same or slightly different way, can get the same result before we publish it. Zach, can an orthobiologic treatment cause a ligament to become too tight? I've never seen it, Zach. It's kind of not a thing now. And why wouldn't it be a thing, right? Ligaments don't necessarily tighten, although that's how we perceive it, we're really talking about taking a lax ligament, which has small amounts of damage in it, and repairing that damage to give it back more normal function. So it's certainly tightening between those two time points, but it isn't tightening from the standpoint of like we're tightening a mechanical device. It's more just trying to get it to repair. So because of that, the over-tightening concept doesn't really make sense with what we know about ligament or tissue healing with orthobiologic procedures. Are there patients whose bodies respond to the injection, so they aren't among the 30% unlucky non-responders, but still did not experience improvement after 2 to 3 ePICLs? Not sure what that one means. The only way to measure the response would be either we're seeing some change in a movement-based metric. So we talked about DMX overhang before, but more commonly that using a validated functional questionnaire, someone's function has changed, someone's pain has changed, their headaches are less, for example. So the question doesn't really make sense as written. Maybe rewrite it, and I'm happy to answer that. Cassian, do you know what inflammatory pathway CGRPs mess with such that they need to be stopped for how long? Yeah, so realize that CGRPs the concept is just taking powerful monoclonal antibody biologics of that MAB class and finding ones that seem to be a little bit more focused on the neuroinflammatory pathway. But at the end of the day, you've got kind of a sledgehammer there. And the sledgehammer is that it's going to block many inflammatory pathways and maybe be a little bit more selective for the neuroinflammatory pathways. And that then started the whole CGRP concept of medications. But in many ways, the CGRP meds aren't all that different from the biologic anti-inflammatories based on monoclonal antibody or MAB drugs that were used initially for rheumatoid arthritis. They're powerful anti-inflammatories that affect multiple inflammatory pathways. And the reason, therefore, you can't use them during this procedure is because they're going to block needed inflammation because inflammation or acute inflammation is required for healing. So if we block that, we're going to blunt healing. So that's the reason why we take patients off of them. Now, listen, just realize that if you're in a situation, and we have these patients, where you can't function off of one of those drugs, then you may not be a good candidate for this kind of outpatient care. What we can usually do in most patients is to take them off for a window, maybe a couple of weeks before, maybe keep them off for 4 weeks after, and then try to restart them to try to get them out of a patient system and try not to blunt that acute inflammatory pathway. Now, is that better than being off them totally or staying on them? We don't know for sure, but it would make mechanistic sense that we're probably threading the needle there with that kind of drug. Stephen, prediction for CCI, neck instability, medical advancement the next 5 years. Yeah, that's a good question, Stephen. I think the most reliable changes will be in orthobiologics in general. What does that mean? A reliable change in orthobiologics would mean that we're going to see probably better technology. We're going to see drugs come online that are more repair focused. We're going to see some of the first stem cells in a vial get FDA approved. Those are the kind of things I think we'll see that may improve what's happening with CCI. Now, CCI as a focus is super duper 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 narrow. Like I said, we've got 5 or 6 surgeons worldwide that do most of the elective surgeries. That tells you how narrow it is, because the total pool of neurosurgeons and orthopedic surgeons that could do upper cervical fusion work is in the thousands. I'm assuming it's in the thousands, maybe low thousands. That sounds about right. So that's definitely going to inhibit advancements in this field, right? If you've got someone that takes an interest like me, that throws a lot of time, energy, and resources into trying to advance the field, then it'll get advanced. But if you don't have those people who are really focused in this area, you're not going to see that. Now, what could bend that curve for everybody, and not only for CCI, but for medicine in general, is if we get into a situation where you start to see AI having a bigger role in medical research and advancement, then we could see more advancements in all medical fields, including CCI, much more quickly. But then we'll have to get rid of the regulatory burden, because it's the thing standing in the way oftentimes of making fast medical advancements. J5, are there less invasive surgeries before a fusion? Not really. You could state that in some Chiari patients, they can get a decompression without a fusion, but at the end of the day, that then just leads to more instability, so not a great choice. You could say that there are less invasive types of fusions, i.e. you get a C1, C2 screw fixation, where they just put the screw through C1, C2. And that's going to be less than like a Golan Harms fusion, where you're talking about bolting the skull to C2 or C3. But at the end of the day, the answer to the question is probably not. Jennifer, in your opinion, Jennifer, let me start over. In your opinion, do you feel many people get CCI after Chiari decompression surgery? Seems like many do. Yeah, Jennifer, so I just talked about that one, but that's a great question. I see it all the time. Chiari decompression surgery, by its very definition, would make CCI more unstable, right? Because we're removing critical stabilizers just to decompress the patient. So, for example, we're removing parts and pieces of the rectus capitis posterior minor muscle and posterior major muscle in order to decompress that patient. And at the end of the day, that increases instability. So by its very nature, it would be almost impossible to decompress someone for Chiari without also increasing their instability. Vera, just curious, how do you flip people over during the PICL procedure? The answer is very carefully. So yeah, Vera, unlike other surgical procedures that you could be in where the surgical team isn't really conscious of what's going on with the neck, and I've seen countless CCI patients get injured that way, we are very conscious with what's going on in the neck. So the first choice is always to wake the patient up and have them assist in turning over. Then we'll help them as they turn over to stabilize their neck, etc. Now, for some patients, they're not responsive like that, right? Some patients come quickly in and out of anesthesia. Some patients do that much more slowly. So in those patients, one person is literally assigned to managing the head and neck alignment as we turn the patient over. So very differently than you would see in like the average surgery center, where it's just not on anyone's radar. Edgar, I'm 6 months out from ePICL number 1, about 20% improvements, type 2B3A. I was pushed a bit hard on PT and feel like that hindered my progress, mainly functional at this point. Would a second ePICL help? Well, Edgar, I don't know your clinical history, so that's going to be a question always for your specific attending physician. But at the end of the day, in general, if someone was 20% out from their first ePICL and they're 6 months out, I would say, yes, we would proceed with a second procedure, assuming there's no showstoppers for that specific person. Cassian, do regen methods work at the adjacent segments of the fused segments, close in outcome to the patient that never had fusion. Casey, so I think what you're asking is if you had maybe a mid or lower neck fusion, is that going to reduce your outcome from something like a PICL procedure? It's a good question. We don't have enough of those in the database. I was just looking at this the other day to really make a go of it. I may try again here pretty soon to see if we've got enough, meaning that if we can compare two groups, we need at least 20 or 30 patients in one group to compare to a bigger group that doesn't have a fusion. My overall sense is that those patients are not going to respond as well as patients who don't have fusions, but we're still going to see responders in that group. So I think that's what we're going to find once we have enough of those people to make a go of that analysis. That's just my sixth sense out of seeing lots and lots of patients in the clinic. Now, usually my gut's right on those things, but sometimes my gut's wrong, right? I would have said that HEDS patients don't respond as well. Ran that now a half dozen times and there's no difference. So sometimes it's my bias as well, like everyone's bias, that kind of clouds, is something really happening or not? Kathy, how does age affect treatment response to this procedure? 30 years of prolotherapy for hypermobility, and now I need at least 2 treatments to get the same improvements. Recent C3 and C4 posterior prolotherapy was amazingly successful. Yeah, so if you're asking how does age impact the response to the ePICL procedure, it doesn't, meaning there isn't an age effect. When we look at that based on young versus old, based on grouping patients into young, middle-aged, and old, for example, or just looking at a continuous variable of young to old and using like an odds regression type thing, we don't see a difference. Now, when it comes to posterior PRP injections, we generally don't see an age difference there unless there's a very heavy burden of osteoarthritis and parts and pieces of the spine where the spinal cord or nerves are getting very compressed, and then there could be a difference. Jacob, hi, Dr. C. This is Anali. Hi, Anali. You've literally saved my life. When I was 19 years old, I had a severe neck injury that left me shaking in bed with almost every neurologic symptom on the list for 2 years until we found you. I've had 3 PICLs and have started living life again. I can drive. I am taking online college. I'm able to finally hang out with friends again. My life is coming back. I'm coming in for another treatment. I just want you to know that you're incredible pioneering with your regenerative. Well, thank you, Anali, so much for saying all of that. Listen, at the end of the day, there's lots of ways to make a living out there, and doctors don't generally do this stuff because it's about the money, meaning I could probably make more money being a real estate agent selling high-end homes than I could doing this stuff. But the reason you do it as a doctor is feedback like that, meaning knowing that what you're doing is helping a patient population that's really difficult to treat and that seems to flounder in getting lots of traditional types of care. So thank you so much for bringing that up. It means a lot to me, and it's the reason why I do this stuff. It's the reason why I spend all the hours I do working with the CCI community. It's the reason why, I was on the phone the other day with Scott Rosa for an hour, geeking out about this new ligament we think we've discovered and how we're going to document that new ligament. It's because at the end of the day, that's what makes me the most jazzed, is seeing that we're helping people who otherwise couldn't get help. So thank you for bringing that up. Stephen, would you say PRP would work well in back shoulder muscles such as rhomboid, traps, supraspinatus, or even biceps tendon? Not sure what's wrong with those muscles, but usually if we're treating muscles, platelet-poor plasma would be the way to go. If we're treating muscle tendons, then platelet-rich plasma would be the way to go. Biceps tendons, for example, if they're not too torn, PRP can work well. And if you inject them in the right spots, PRP can work well. So I'm not quite sure what's going on with you, but hopefully that helps. Thank you, Jennifer. Again, guys, I'm just going to start wrapping this up here because I got more questions than I can answer easily. But do me a favor, give me a like, share, comment, subscribe. Again, the reason for doing that is simple. It helps the algorithm find this content. It helps other CCI patients get help. So do me a favor if you haven't done that yet and just hit that like button, for example. Let's go on here. Gurav Dasan. How does weight impact overall recovery? I've been gaining weight because I'm not as active as I used to be. Yeah, so as I said before, metabolic syndrome, I believe, can impact, well, certainly impacts overall health and probably impacts recovery. Now, the question remains open whether it impacts the final recovery, but it probably makes recovery harder from all procedures, including this one. So what I tell patients is, if you can control your weight with diet while you're less active, then I would do that. If you can start moving to a low glycemic diet, i.e. get rid of the Starbucks Frappuccinos, for example, that have 70 or 80 grams of sugar and are like drinking a cup of simple syrup, do that. And if you need more help, consider a GLP-1 drug. Those are really common and easy to get these days. But in general, getting rid of metabolic syndrome, extra weight, high blood pressure, blood sugar instability is a net positive for overall health, and it's certainly a net positive for recovery from any procedure, including this one. Jay Gardner, hi, Centeno. I'm scheduled for my third PICL next month. They have been spaced out for months apart. I will miss out on the additional healing my body will do between, or maybe will I miss out? Yeah, I don't think we generally see that. So I think I've answered that before. I think I actually have a video coming out, a little YouTube short on that topic, but I'll answer it again. At the end of the day, what we tend to see is a healing cycle where the big part of the healing and the heavy lifting is done in that first, let's say, 4 weeks. And in that first 4 weeks, you see the acute inflammatory response, you see new tissue getting laid down. After that, let's say at 6 weeks out, 2 months out, you're really more involved in tissue remodeling. And tissue remodeling means is the body is trying to adjust the tissue quality and align fibers to meet the demand or load on that tissue. So if you were to restart a healing cycle at, let's say, 4 months, when you're well into that second or third phase of healing, which is remodeling, it's not going to negatively impact anything. Instead, it'll have a positive impact. Now, if you were to keep beating a dead horse, for example, and what I mean by that is in the middle of an acute inflammatory response, let's say at 2 weeks, and just repeat the procedure at 2 weeks, 2 weeks, 2 weeks, you could have a negative impact on the overall recovery and healing cycle, but it's not going to happen that far out. Tyler, I'd guess that testosterone would be more useful, not for the stem cells, but rather for building more muscle in the back neck, which supports everything else. Now, Tyler, I think you'd be right there, but you'd have to be active to take advantage of that. So realize that testosterone can build more muscle, but it's only going to do that in response to load. So I've seen a lot of skinny little guys walking around that don't have much muscle that are on testosterone. And then you see guys that are on the same diet or the same amount of testosterone, but they load those muscles and those muscles get bigger. So realize that you need 2 components, testosterone plus load, in order to get big muscles. Big muscles don't just happen with testosterone. Let's see here, try to get some people in who haven't had a chance to get a question yet. Let's try this one. What are your thoughts on MCU BTE neck machine? We have an MCU in the office. You know, it's an advanced neck strengthening regimen. It's a specific machine that loads the neck in lots of different axes. So I think it's great for the right patients. It would have a big crash and burn component, though, for most CCI patients. It's a little bit like other things that I've talked about, right? Everything works well if it's sequenced at the right time when the patient is ready for it. But for that particular type of strengthening, we would have some patients that are ready early, but not most. And we would have, let's say, half of the patients that would get to be able to use an MCU at the right time. But it's not going to work well in the wrong patient at the wrong time. Otorix. If my overhang on the DMX was only at 2.3 and only on one side, with the other side not having any significant overhang, does this rule out AAI, or could it be muscle tightness masking? So Otorix, it certainly could be that either muscle spasm is masking more of an overhang, or we very commonly see that the patient isn't pushed far enough. So when I say pushed far enough, that's probably the most common thing, is getting enough lateral bending with that head absolutely straight looking forward and the mouth open to show the overhang. That's a common one where you will see what you're describing, which would be a false negative test. Now, it's also possible that despite that, the muscle spasm is hiding it. We do see that sometimes, but it's more rare, right? I'll see that with atlantodental interspace. I've only seen it a handful of times now that I've looked for it, maybe 4 or 5 out of hundreds and hundreds of patients where I've looked for this. But that does happen where the ADI won't be present on a DMX. It won't open up, but it does open up under anesthesia. But it's usually not getting enough lateral bending. Now, if you're getting that amount of lateral bending, which is usually at around to 45 degrees or so, and it's still not showing up, it's just probably not there. Nathan, what aspects likely cause the initial 1 to 3 day post-ePICL flare? Usually, Nathan, that's the acute inflammatory response. So what is acute inflammation? Acute inflammation is when those initial cells come in to start the repair response. So inflammation solely means that the body or the platelets or the stem cells that are put there are calling other cells into the area to try to do a couple things. The first thing that happens is a demolition of the stuff that needs to be demolished, right? So think about a construction crew. Let's say there's a house remodel and the house is falling apart, right? The construction crew comes in, identifies what it is they're going to keep that's still good, what it is they need to get rid of because it's bad. And the first thing they do is to start the demolition. That's what's happening in that first 1 to 3 days. The crew is recruited and it's coming in and demolishing and taking out the stuff that's not helpful. Then after that, what does that construction crew do? Once the demolition is done, they then start putting in the new stuff. So they'll come in, they'll start maybe structurally shoring up some parts and pieces. They'll start laying new drywall because they wanted to move the walls around. And as time goes on, they'll refine that space. So for example, eventually they're painting, eventually they're bringing in all the appliances, they're bringing in the new cabinets. They're putting the finishing touches on making it livable up to the standards that they want to try to achieve. Same thing is happening in the body. You've got that second crew coming in and installing the big structural stuff, and then the finished crew coming in and dialing in what that tissue needs to do so that it has the right tension and has the right tolerances to support the loads. Brett, my symptoms began suddenly 8 months ago with no injury and have drastically worsened. My main issues are severe brain fog that feels like that I'm drunk 24/7, dizziness when upright, visual disturbances, non-novic instability, POTS, DMX showed 6.2 to the right, 7.8 to the left, but I have no neck pain and no confirmed DDS. How do you distinguish true CCI from sensitized nervous system, and can a large overhang be congenital and previously asymptomatic? Brett, it's certainly possible that large overhangs could be congenital and previously asymptomatic. But the good news is we have the Katz et al. Study that looked at how likely that was based on the amount of overhang. So if you have an asymmetric dens in the atlas and you've got more than 4 millimeters of overhang, in which case you do, then the likelihood that it's asymptomatic is about 5%. So that's 1 in 20. 19 in 20 would be that it's causing the symptoms. Now, it certainly gets harder when someone doesn't have neck pain and when someone doesn't have headaches, for example, because then we have to start using tiebreakers to try to see, is this for sure causing this person's symptoms? So a good one for that would be a hands-on exam. We can get in there, or I can get in there and determine, is the exam localizing the upper cervical spine? Hence, this is probably causing the symptoms. Or not, in which case we still don't know. And then we can look at other testing. So we use that neck care device to look at proprioceptive clues, for example, to try to see if that points to the upper cervical spine. So again, I don't think we'll ever get to 100% certainty, but we do lots of different things to try to up the certainty that we're treating the right spot. Sarah, what do you think of manual therapy before PICL? I think if it's the right manual therapy, I think it's great. So for example, upper cervical chiropractic, which is focused on vector type adjustment with very low force, great. Big neck cracks, not good. So it gives you some example there. Jay Gardner, have you seen patients get better with just PICL that still don't have a good neck curve? We have. Okay, let's see. Diana, can CCI AI make it feel like the base of the skull is broken? It can. I certainly have CCI patients that describe their symptoms that way. A lot of times that comes from C1, C2 facet joint pain. If it's pain kind of like right back here. But yes, I've seen a lot of CCI patients, or some CCI patients, describe their symptoms in that way. Stephen, how is it that pulsatile tinnitus is caused by IJV compression? What are other symptoms caused by IJV compression, and can it be fatal? Well, going backwards, IJV compression is rarely fatal. So that is something I don't think I'd even be concerned about, because we see IJV compression that's severe even and bilateral in people that don't have symptoms about 1 in 5 times. So the idea that IJV compression is going to kill you is probably not a viable concern, or one that you'd be super concerned about, right? In all likelihood, you would probably have a higher risk of dying in a car crash randomly, or a higher risk of dying in some other random event than you would IJV compression based on the data. As far as how IJV compression causes pulsatile tinnitus, I don't think anyone knows for sure. There are lots of theories about how tinnitus is generated, but as many theories, or more theories than certainties about how that works. Have you seen prolotherapy reduce C2-3 forward slippage? Yes, we have published a paper on that one 2 decades ago. So just look that paper up. If you look up Centeno and prolotherapy on PubMed, or it might come up under Centeno and dextrose injections, that kind of stuff. Odorix, how much better are the results when using stem cells compared to only PRP? If you mean bone marrow versus PRP, just depends on what it is you're treating. There are things you can treat where they'll be pretty equivalent. There are things you can treat where the bone marrow will do much better. Zach, yeah, Zach, this may be getting in too far to the weeds for this particular more patient focused. And I don't think anyone knows the answer to this question at this point, but far, far, far too deep in the weeds here to help other patients. Let's see. What fluoro angle can the OA and AA joint be seen best? Straight AP doesn't cut it. AA joint, it's variable, so you have to literally adjust the angle of the beam to crisp up the C1, C2 joints. The C0, C1 or OA joint, you can't do that. You're only seeing the bottom of the joint. There is no way to see directly through the whole joint since it's a cup-shaped joint. Okay, guys, more questions continue to pour in. I'm looking at least a couple dozen more, and we're at 1 hour and 16 minutes. So I'm going to go ahead and stop this for today, but I want to thank everyone for all the great questions that they've asked here. Again, give me a like, share, comment, subscribe, because that's how people find this content. And why I love this format is because all of these questions generate new information for other people. So thank you for doing that, because by coming at the same topic even from 5 different angles, someone might not learn it from coming in from this angle, but they might understand it from coming in at that angle. So thanks so much for doing all of this and being here with me on Sunday mornings. I should be here next Sunday, and we'll have another topic to talk about and then lots of Q&A. But thanks so much and have a great week and have a great Sunday.